So good morning, everyone. This is our 15th distinguished lecture today, and it's very, a pleasure, and we are honored that Dr. Madhumita Dobe joined us. She is with us as a mentor, as a team leader with us in MERA-India program in Community Behavior Health Group. And we have heard her multiple times in discussion, and we had a lecture also. So we are well aware about the expertise she has. But today is I would request all the community, especially community behavior people and community medicine people. This talk is going to be very special for us. Last time we heard Dr. John Uman, and he taken us through the India malaria journey. And in this context, today we have Dr. Madhumita Dube, and she will, talk about community behavior, health involvement, and the significance of this in malaria elimination. So before we start, I would like to read a few lines about Madam as an introduction. Dr. Madhumita Dube is the former Dean and Director, Professor Public Health, and former HOD, Department of Health Promotion and Education at All India Institute of Hygiene and Public Health, Kolkata. This is in Ministry of Health and Family Welfare, Government of India Institute. At present, she is the chairperson of FAITH, which is Foundation of Actions and Innovations Toward Health Promotions. She has an excellent academic record with the several scholarships like NSTS, JB, and STS, and gold medals in medical degrees program in MBBS and MD. She is a well-known figure, as I told you, in the public health. She continues to contribute through her teaching, training, research skills in different disciplines of public health, especially community health behavior, public health nutrition, health education, social and behavioral changes communication, and One Health for capacity building, program planning, implementation, and evaluation. In addition to that, she is an international trainer in capacity building for health promotion conducted by WHO CRO in public health promotion. She is a member of Mission for Independent Assessment of Kala Jar Elimination Program in India, organized by WHO Country Office in coordination with the Ministry of Health and Family Welfare and NVB-DCP. She is an expert member of the Joint Monitoring Mission for Elimination of Lymphatic Filariasis program organized by NVB-DCP in collaboration with WHO Country Office. And she is a mentor of multi-scientific projects on community behavior theme by our group, which is MERA-India, ICMR. She is on expert advisory panel on hygiene and public health in developing countries. She is a member of advisory board of World Federation of Public Health Association and Secretary General for the Indian Public Health Association. She has been expert member of multiple other international bodies in the area of public health. So with this brief introduction, I request Dr. Madhumita Dube to start the lecture. Madam, please.
Thank you. Thank you, Sachin, for your very kind words. And before I start sharing, let me say that I'm really thankful to MERA-India and NIMR for bringing community behavior into focus. This is the last mile which you have to go for malaria elimination. Goals are in sight. And rightly, you have pointed out that now is the time to think about the community, with the community, for the community. So with these words, let me start sharing my presentation. So though this is not really on a negative note, there are failures, and failures help us learn. So I would like to just discuss with you to relook, to rethink on what we've been doing about community behavior all this while. Not only in malaria, I think it applies to every program or every project in public health which we undertake. But definitely we look forward to future successes from these learnings. Each failure teaches us certain things. So there are challenges. There are multiple challenges in changing community behavior. First of all, we must remember that malaria prevention efforts, actually, they depend very heavily on behaviors occurring at multiple levels. It's not only the individual, there are household factors, there are community behaviors and societal behavior. And behavior, unlike machines, human behavior, unlike machine behavior, is very complex. So interventions have evolved, And as you have already heard from Sachin, we are in a process of understanding more and more about making better interventions in this respect. But we have to remember that no matter how efficacious an approach we plan, it will only be effective if people engage with it and use it appropriately. So now, colleagues, researchers, and friends, I would like you to look into ways in which we can engage the people for whom these programs are meant. People need to be engaged in obtaining good quality insecticide treated nets through available distribution channels. They must use the nets consistently and care for them appropriately. Then comes the big other preventive aspect of indoor residual spraying. Again, that depends upon well-trained spray teams, people accepting these teams in their homes, agreeing to remove their possessions from the house before spraying, and refraining from major post-spray modifications like painting or hanging decorations in their walls, which can reduce spray efficacy. These are easier said than done. So now we also need to look into what prevents them, what acts as barriers for them not doing these. Moreover, not only prevention, individuals and especially caretakers of young children must promptly seek care for fever and they must complete the treatment course. Likewise, for pregnant women, they need to take the recommended doses, etc. So now the focus on is moving the provision of malaria services for first line treatments and rapid diagnostic tests into the community. These are the challenges which have been overall seen all over the world. This is from the GMAP. So, this is not only something which we experience in our own country, it has been experienced all over the world in different degrees, in different parts where malaria, particularly malaria, is endemic. So, what has been our learning? Our learning has been we have long depended upon the KP theory, the knowledge attitude practice theory. This was proposed way back in the 1960s when we started understanding that knowledge is a necessary component of behavior change. But as time went on, we also realized and learned that only knowledge will not be sufficient to bring about behavior change. Like we all know, when smoking, this is a very good papers have come out. Even when smokers are shown cancerous lungs of other smokers removed post-mortem, they decide to stop smoking only for 24 to 48 hours. After which, again, they forget and they start doing what they were doing earlier. So, this is another thing which we need to understand when we are talking about community behavior. It is that people may or may not change their behavior just based on their knowledge or perceptions. Because in each one of us lies some psychological defense mechanisms protecting what we have been doing. This is what we call cognitive dissonance. We know, but we don't do. Again, another common misconception is that we use knowledge and perception synonymously, but they are not the same. Perception is a more important predictor of behavior, how we will talk about later. Perception is the interpretation or meaning which a person or a group of people give to information or data which is available. This is dependent or modified. The knowledge is modified by the experience of that particular person or the community. So this is based on the need and motive. So knowledge is not equal to perception. And there is another thing which we talk about is the perception of likelihood of acquiring a disease, which is we also call risk perception. This is an important influencer of behavior change. So now we have to move from knowledge, beyond knowledge, to perceptions and risk perceptions. Another thing which we very commonly use is attitudes. We say knowledge will improve attitudes and attitudes will improve behavior. But they are not motivations. They are orientations to a particular issue. They can predispose, but they per se attitude will not activate behavior change. Because attitudes again have several components, which we call the ABC model of attitudes. When we are assessing attitudes, we also have to take care that we are assessing each of these components again. there is an affective component, how an individual feels about something. Like for malaria testing, people might feel that I'm afraid of pricking my finger for a blood test. This is the affective part. The behavioral part or the cognitive part, the way the attitude influences, like I start sweating due to panic when I enter the place where blood slides are taken. I cannot see the sight of blood. So that has to be assessed as well. Then comes the cognitive component. This is modified by belief and knowledge. I believe these medicines are not safe, so I'm not going to take these medicines for a long while. So when we are assessing attitudes, we have to take care, if at all, that all these components are well assessed before we can plan any change based on attitudes. Because as again, I will be talking about in many of the future processes also, attitudinal assessment forms an important component. So what have we been doing all this while? We've been looking at community behavior through the knowledge, attitude, and practices lens. And you can see all these papers from the world over, particularly I've taken Indian journals, and you can see that 2022, 2014, ranging all this part is knowledge, attitude, and practice. So we have a lot of knowledge on that. And based on that, all our interventions towards elimination has basically focused on increasing knowledge. This is just a screenshot of the NCVBDC. You can see all the BCCIC resource material focused on knowledge improvement, like making several posters, making sometimes videos, you have posters, leaflets, stickers, wall paintings, in plates, signages, etc. So that's what we've been doing. But in the meanwhile, there has been paradigm shifts in understanding community behavior. Traditional health education, what we always used to say or do, assumed that by increasing knowledge using IEC strategies and other information, there will be an attitudinal change which would lead to behavioral change. But it ignored the other constraints, the environmental factors which act as constraints to voluntary change. Unless change is voluntary, it is not sustained. So then, having understood this, we tried to move into a new strategy, behavior change communication, where we said, okay, along with this knowledge, attitudes, we also will have to provide a supportive environment, affordable, accessible, adaptable, or rather, uh, whatever the community, whatever the barriers are there in accepting these services or making them available or making them available, affordable, those are the issues we tried to look into when we tried behavior change. But that too was found not to really sustain these changes. So what happened was one started looking at other models. What really sustains behavior change? Is it individual behavior alone? Or is it the behavior of the people with whom he or she has good relationships? Is it the behavior of the community as a whole? Or does societal behavior also play a part? So for sustainable behavior change, we found that it's not only personal, but also societal and environmental factors which are very critical. In fact, there are certain tipping points. And when you do the research in this line, you would find that addressing the tipping points are absolutely essential for sustainable behavior and social change, including changing policy and structural issues. So we cannot ignore that when we are thinking of change. So it's just beyond KP. So of course, knowledge is essential. And take the case of vaccination. Vaccination practice is good, even with low levels of knowledge, improper attitudes, because there were other influences, So each program has its own uniqueness, but people group together in communities in order to survive. So living together, people form certain common behaviors and habits and cultures. So we have to analyze and look into the influence of culture on health, because that affects perceptions of health, illness, death, beliefs of how disease, how illness are experienced, and attitudes. So attitudes are there. Beliefs are there where ideas are accepted as true without facts also, and values are there. People or communities have their own sets of principles which they consider of great importance. I will not reiterate into the Chinese saying, but we all know that we have, in order to change, we have to start with what we have. So we need to know what they have. The other important issue which also comes up and which is very essential in last miles of all elimination programs is looking into the health inequalities and health inequities. So what is an inequity then? We find that social contexts, all these social contexts create social stratification. Social stratification again will lead to differential exposure towards health damaging conditions, differential vulnerabilities, etc. So social stratification will determine differential consequences of ill health, which is very evident also in the malaria program. Now, some of these inequalities can be remedied or avoided. These are the ones which we call health inequities. Inequities are shaped by social determinants. So what remains for us to eliminate in this last period are these inequities. I have tried to exemplify this with this diagram. What we are trying in universal health coverage or whatever we try is equal sized or equal programs for everybody. But everybody is not the same. As you can see, this tall one here can easily see. The not so tall one also somewhat manages, but this short one is unable with the same size boxes. So the smaller one needs a larger box. So one size fits all, this concept has to be removed. And to understand that which size which fit this person, we need to have more studies on the social determinants of health so that we can make the programs to measure. So what the health sector cannot control. The health sector cannot control dwellings amidst paddy fields in malaria endemic areas. So what I want to reiterate here is the importance of teamwork and multidisciplinary inputs, not only in assessments, but in implementation, in design, and in evaluation as well. Particularly in One Health, this is coming up in such a big way, and it will give scope for all these programs to be more successful. So as you can see, there are dwellings in malaria endemic areas, ideal ecosystems for mosquito proliferation, waterlogged paddy fields, this is seepage water. But what can we in this sector do? So this needs inputs, hand-holding, and collaboration, referrals, working together with other sectors as well. So which brings us to the socio-ecological model. This is the model based on which we need to now progress. We understand that the self is at the center. They have an interpersonal concentric ring, outer community ring. Then, but most important is that unless we change this also, the enabling environment, understand that what is going wrong at this level and at this level, through information, through motivation, through the ability to act, and by understanding the norms and then trying to change these. This is where our future work lies. What was lacking and what needs to be done is the evidence base. We need more research about target audiences, not only in the beginning, of course, in the formative stages of an intervention. We can use various qualitative methods to understand context, beliefs, preferences, constraints, motivations, and current behaviors. We also need to pre-test whatever we are trying to implement, concepts, materials, and I'm glad that in Community Behavior Project of MERA, we have tried to incorporate some of it. It's a first baby step, so there will be much to do later as well. After program launch and throughout the program, we need to monitor processes. That serves as evidence whether it worked or not. And finally, to evaluate impact and analyze the reasons. Here we can use quantitative methods like KP surveys, anonymous client surveys as well as qualitative methods through mixed method researches. The second thing, which is very important, but which till now has been very lacking in all our research bases, is the theory base. Many communication activities amount to pure advertising or promotion without any examination of why an audience is not yet performing these ideal behaviors and what might influence them to change. So, planning interventions, there are several theories and frameworks of how change will occur. These are the logical processes. We have to base our studies on that. So, all involve research to look at the determinants of behavior, factors that will either constrain or facilitate change. We need to analyze them, all our determinants, according to these theoretical models and frameworks, because that will help planners to logically focus on the factors that are central to people's willingness or ability to change. The other important thing is that we are yet not analyzing the context in which change is taking place. There are social systems, there are health systems, etc. Each provides a context. So we need to analyze each system. Family decisions about prevention and treatment, they are potentially affected. This is what I've tried to give you some examples from the health system, which are the actions of community volunteers, providers, health system structure, or health policies which are affecting the family decision. What is the level of trust? What is the system of referral? Is there a disconnect between public health system and traditional healers? Because these are the typical barriers. Besides this, we also may require looking at economic and social systems, resource, time constraints, etc. Gender issues come in a very big way. Legislative issues, taxes and tariffs on anti-malarial commodities. In fact, I've found a lovely paper on this from Africa, where they've tried to analyze this and find whether this changing these would improve affordability and acceptability. And of course, influences across sectors. We were talking about education, housing, agriculture, etc. So we have to remember that when we are planning interventions, be it communication, be it otherwise, it has to be based on a process. And this is the P process. Malaria change strategies and programs designed in the absence of data on these behavioral determinants will fail to address fully the needs of the individuals and communities. So we need to consistently measure behavioral determinants in terms of theoretical frameworks to get the context and the individual factors. We need to conduct formative research because even the messages we formulate is decided centrally. No, it needs to be done. Again, one size will not fit all. We will need to understand context-specific needs and target our messages that resonate with the audience because they have their cultural, interpersonal, and even seasonal behavioral priorities. Then it has to be a multi-channel approach. No use spending a lot of money on one channel. There is a dose-response relationship between the number of sources to number of message recalls. And again, number of message recalls and likelihood of adoption. No single channel alone, papers or research has shown, no channel alone can reach more than 1/4 or 1/3 of households. So the final thing, which is very important, which is again a very logically, scientifically validated process, is community mobilization and community engagement. We use it very casually. Community-led efforts have been shown to resonate better, but it has a process again. This was an ideation model. I thought I would just share it because they followed a theoretical framework. Those of you who are interested can go and look into it. It was done by Kincaid, one of the very important behavioral and social scientists who studied mass media, ideation, and behavior, did a longitudinal analysis of contraceptive change in the Philippines. And this is how he used skills and technical knowledge improvement, cognitive, he found cognitive elements, emotional elements, social interactions, and then provided environmental support. So he gave instruction, promoted these ideas, and advocated to improve the intent of performing the behavior and finally the behavior itself. So this is just an example. There are numerous models which can be adopted. But obviously you will be saying, this is a huge thing. This is impossible. How do you eat an elephant? But of course, an elephant also can be eaten. It's just one bite at a time. We need to prioritize where we will be starting from, the back, the bottom, or wherever. That again will depend upon your assessments. So community engagement again, thought I'd just touch upon it. It is a proactive and iterative process. it is not an end in itself. It has to go on. Most programs take the design to the community after it is finalized. But it is important to include the community in the initial design and then find ways to continually engage them throughout the process. It's a learning process. We can never go with the idea that I know better than them. I've gone to learn, and I will learn with them, design with them, implement with them, and evaluate with them. This also helps to respond to rumors or changing because attitudes and perceptions also change. So we can quickly and effectively target and engage. It also is very essential to establish a transparent feedback loop, continuous communication, giving them tangible feedback on program results and milestones. Only then will they remain invested. So, this is a vital component of efforts to expand access to care, prevent disease, and whenever we are engaging the community in that group, it's a teamwork. So, in that group, we have to keep representatives of the marginalized and vulnerable, hard to reach populations. Only then we can hear their voices and work accordingly. So this is an essential component in a shift towards creating local and site-specific solutions, which will be the problem in the last lap of elimination. So this is just to tell you that what happens often is co-option. We choose local representatives, but give them no real input or power. Or often we have compliance, we just give them tasks and give them incentives, but we decide the agenda and direct the process. That too is not community engagement. Sometimes we even ask for local opinions, and outsiders will analyze and decide on the course of action. That too is not fully community engagement. Cooperation, we work with them to determine the realities. But again, what will be done with them, with those realities, depends upon the outsiders. No. Finally, what is community engagement is collective action and co-learning. Priority health and social concerns will be expressed by the community through participatory learning for action. You know, this is another research tool which is very commonly used, and it should be used more and more. The local people set their own agenda and mobilize to carry it out in the absence of outsiders. Okay, and co-learning. Take it as a learning experience. Both the local people and outsiders share knowledge to create a new understanding, work together to form action plans, with the outsider, like you and me, only facilitating. That is community mobilization, which will be sustained and lead to grassroots-led actions. Finally, because this is a research organization, I thought we'd just point on or focus on a few issues which you can take up. Right now, we have lack of understanding of social norms and beliefs which guide community behavior because we lack methods and understanding of precise measurements of social norms and beliefs. So as I said, it should be a teamwork with other experts and specialists pitching in to form these measurements, to give us this, help us gather this data, to give us good methods of understanding this. Second, lack of research identifying the gaps between access to resources and actual adoption and maintenance of those behaviors. We have a lot of quantitative studies on this, but the link between the two has not been studied till date to a very great extent, or less published at least. Less mixed methods research with joint displays. In fact, in this community behavior project, I was harping on people since we are having a GIS display also. So that GIS display could be used with findings of qualitative studies jointly displayed on it, which would give a lovely visual expression for the community. Also, it's good to understand. All visual displays are better to understand. And well, this must be used more and more. Finally, what I said is lack of research grounded in theory. We need to understand these common behavior change theories, adopt a few of them, and conduct research on it to give us a better understanding of the social behavior change determinants. And finally, while doing this study or preparing this presentation, I found there was a gross lack of peer-reviewed articles adequately describing social behavior change programs. So that remains things for you all researchers, students, and colleagues participating in this discussion to look into future. You are the wonderful brains of India, so we should not be having these gaps. Finally, before we end, on 2022, there was focus on innovation. We need, always in the last mile, innovation also needs to be harnessed. So this is just an example of designing a malaria elimination program for hard-to-reach communities who have difficulty accessing healthcare. So this, I will tell you, this is a malaria amongst people living and working in and around remote forests. And this was done in Lao PDR. Lao PDR started piloting innovative approaches. These are known in that country as accelerated strategies. Pardon me for the pronunciation, but I understand this as Khamuan province. From July 2021, they did it. And they did it with the villagers. A wonderful finding came out. The villagers, they mapped the diversity in malaria hotspots, malaria burden, languages, beliefs, health practices, and movement patterns. So what quickly emerged was a picture of highly distinct communities with complex epidemiological and cultural influences that were having an impact on malaria transmission. So you see, community engagement and using the community gave wonderful results. And along with it, we must also use and harness the increased availability of all our ICTs, mobile phones with voice, SMS texting, video capability. So this has revolutionized speed, cost, and control of communication. We can use it for innovations. Even remote groups can be reached virtually, instantly, and in any language. And here what happens is we've seen during the infodemic in COVID, communication takes place through horizontal channels. Consumers, clients, they create their own messages, they receive their own messages, and information goes viral in a flash. So we need to understand what is the access to these new tools, harness their power, and use more newer partners in spreading the message to change community behavior. These were some of the references which I have used. And thank you very much, MERA-India, for giving me this opportunity of once again voicing my passion in these areas. I do hope at least some of you will be enthusiastic enough to take up some of this work for India to understand the current situation better and to move towards elimination of malaria, which remains an ambitious goal as of today, but it should be possible by 2030. Thank you very much.
Thank you very much, madam, for your, as always, wonderful, very descriptive and informative talk. And, I can see that our PIs from different, zones are joining us. They are listening to you. And I can say this is very well articulated talk, as always, from you. And I don't see any much question, because this is explained very well in the area. But I'm sure because Bhavna is handling this theme, community behavior, here, so she has some questions here. Bhavna, you may ask directly.
Yes, thank you, ma'am. It's wonderful to always hear you. So my first question is, like, in this age of internet, when information, whether it's right or wrong, unfiltered, is available to everyone, so how do we make sure that community behavior or the expected changes are on the right track? I'm just taking a recent example, like for the booster doses, where the government was promoting the booster doses, but then there were some myths and misconceptions that, okay, these lead to adverse effects, which were preventing people to go for the doses. And how critical is it that the government or the authorities come up with the right data, correct information to the community to allay their fears?
Yes. As you have rightly pointed out, Bhavna, and I shared in the last day, so ICT is now a threat and also a tool which you can use. So having expected this, that it will happen, you cannot stop it. So we need to actually, even during our studies or our sources or our research into media exposure, one needs to find out what are the channels of spread in particular communities. There is always a pattern. There is everywhere a pattern of spread. There are people, and of course, there are some other people who want to create havoc. So they are also working from outside the community. But you can always use good sources within the community, prime them beforehand, take them into your confidence, engage them, informing good messages, and what they lack is the scientific validation of what you say. So, as I always say, when you pass any message onward, you must also say why or what is the science behind it. So, in their terms, not technically, but in their terms, so that it helps them understand. They become more confident. Community ham radios and others in many places have been used very wonderfully. So, being prepared for this beforehand, identifying sources who can help you counter these and spread the proper messages, and be prepared for it. I think that's the answer.
Right, ma'am. Thank you, ma'am. And just one more question, like
Yes.
that we have also seen in our community behavior project. Uh, Traditionally, the data or the perceptions are collected through paper, right? On paper and then passed on, managed. I don't know how tedious it would be to manage this volume of data. And now with the technology coming up, but again, we still have seen, observed that in some villages, people are not really welcoming if you have a tablet, data collection tablet in hand. So, any thoughts on this, ma'am? Empowering the health workers or the workers who are going to the field to collect the data.
Yes. The only thing is that whenever you collect data on iPad or whatever tool you must be using, the communication with the provider gets disrupted. Each time you look back, you get that. So there are two things which comes out from your question. One is this tool taken as a threat? As a threat for recording, passing on, etc. So that needs a bit of preparation. For working in the community, the preparatory part has to be proper. Rather than jumping on and starting data collection one fine morning, you need to go and talk to the people. Well, this is what we will use. Give it in their hands, ask them to operate if necessary, and let them feel free with it. Let them not see it as a threat, firstly. Secondly, besides even yes and no and answers like that, we do use documents, pictures, video recordings. There are so many other ways in which also data can be collected. But the first thing is the community should not consider it as a threat, right? So you would see, if you look into some of the recordings of foreign countries, they blur the faces when they are presenting. So you could adopt something like that to see whether they accept it. Talk with the community, what will make them accept it, and work accordingly.
Right. Thank you, ma'am.
Thank
Okay. So, madam, before we conclude, I know you are not well, but you highlighted, research gap in your last slide.
Yes.
So my request to you is your expert advice on, especially on the lack of understanding and precise measurement of social norms and beliefs.
Yes.
And the second one, malaria-related behavior and actual adaptation. What would be your to fulfill these research gap? What would be your
The
expert
types of
advice on
research, Sachin, need to change. We have for long focused on only quantitative because, of course, it is easier, uh, more cost effective, and things like that. But even if done on a smaller scale, and for long we've thought of things which are representative and validation and all those, but it is equally applicable in social research. There are ways and means of doing it. So we should form a team. We should get social scientists in it, see how they examine the social norms, might be adopt some of that into the health sector, and be able to identify the social norms and beliefs pertaining to malaria in your case, which might need to be changed. That is one thing. Secondly, we talked about the second part was what, Satin? The
second
second
is
part of your question?
malaria-related behavior and actual adaptation.
Yes. When we are talking about malaria-related behavior, again, we identify certain behaviors, preventive, certain treatment-wise, but what actually guides this decision-making process? And that's why I was thinking of using some of the theoretical frameworks to fit these, what we call as variables in ordinary research. In this case, we call them as constructs. So variables used in theoretical frameworks are constructs. Try to see whether they fit into these constructs of the framework. If they do not, might be we might evolve into a new theoretical framework from MERA-India's work itself, but we need to do more grounded theoretical framework grounded research. That would give us more logical outcomes. That's my opinion.
Thank you very much, madam. Thank you. And we would like to thank you from the entire MERA-India team and NMR and ICMR. And I would also thank you to all the participants who has joined us. I am sure they are getting, the final message from you on the community behavior, role in the elimination of such diseases. So thank you very much, madam. Despite you are not well, you joined us. Thank you so much from all of us. And
thank you, Sachin. I mean, as always, I'm very grateful to MERA for giving me this opportunity, and the pleasure is mutual. Yes, of course, we do hope to see more of such work in future.
Yes, madam. Yes, madam. Thank you very much.
Thank you.
Before we conclude, next next talk would be from Dr. Mitali Chatterjee, and she will talk on Kala Azar in the lecture series of.
It's a very good friend and a junior in the same alma mater. So yes.
Yes, madam. Okay, madam. Thank you so much, everyone.
Thank you.
Thank you.